Dear colleagues, as you know that I had a presentation today in EHRA 2022, but due to power cut, we couldn't complete the session. So I will try to present my presentation with this way. And today I will try to briefly discuss cardio-neuroablation strategy in reflex syncope, and I will try to give an answer to the question, are we ready for this strategy? Actually, to neuromodulate autonomic nerve system or to ablate parasympathetic system, we should understand the cardiac neuroanatomy because it will completely affect our ablation strategy. And actually, as you know that, although most autonomic ganglia are embedded within the epicardium, we should understand that there is a highly dense network of efferent nerve fibers in myocardial and even endocardial levels. So during endocardial catheter ablation, we can ablate both these postganglionated neuronal fibers and epicardial autonomic ganglia. But as an important point, if we just ablate postganglionated neuronal fibers, our lesion will be transient due to axonal regeneration process in the long term. So during endocardial ablation, we should target real epicardial autonomic ganglia site. Actually, according to old concept from experimental studies, especially from the smaller mammals, we believe that most GPs are embedded around 3 epicardial fat beds. And actually, this belief completely changed our surgical ablation strategy, like in AFECT study. But this is only true in smaller mammals. If you look at the bigger mammals, and if you look at the studies on the bigger mammal hearts, which focused on the determination of location of epicardial ganglia using histological examination of heart sections, actually, we know that in some well-defined left atrial and right atrial area, we see clustering of autonomic ganglia, which is called as ganglionated plexus, defined grouping autonomic ganglia in different atrial parts. So now we should understand that actually the real concept should consist in some well-defined atrial part. There are grouping epicardial ganglia, which are called as ganglionated plexuses, and we see some postganglionated neuronal fibers from this GP site to target organ, like sinoatrial node, atrioventricular conduction system, or even ventricular level. For example, if you perform ablation endocardially in this site, actually, in first attempt, you will dissect postganglionated neuronal fibers from right superior GP to sinoatrial node. Please remember the localization of sinoatrial node in here. So you can see a steep increase on heart rate levels because you can transect the parasympathetic postganglionated neuronal fibers. But then if you follow these cases more than 12 months, you will see a decrease on heart rate levels due to axonal regeneration and reinnervation. So to completely eliminate parasympathetic innervation of sinoatrial node, we should target real epicardial autonomic ganglia of right superior ganglionated plexus. This is a very important point. So the next question, how can we detect localization of GPs during electrophysiological study? Actually, different groups use different techniques, and I think that all techniques some well-known limitations, like high-frequency stimulation. You can induce inadvertent atrial fibrillation. There is no prepared protocol. The positive criteria of positive response is not identical between studies. And if you use general anesthesia, it may cause the blunting of vagal responses. The second option is spectral analysis, which was defined by Professor Pachon, but it's not compatible with the current 3D mapping system. And some groups use empiric anatomic ablation, but it may cause a larger ablation because you will not have any ablation endpoint if you use just empiric anatomical ablation. And we are currently use electrogram analyzed based GP ablation strategy. Actually, in our previous work, we compared two techniques. In the first arm, we performed high-frequency stimulation plus spectral analysis by using offline computer analysis. And in the other arm, we just targeted fragmented electrograms by changing bandpass filter to 200 and 500 Hz and compared the procedural characteristics and follow-up data. And at the end of the study, we found a shorter procedure and scopy time in the EGM-based strategy arm with a similar effect on heart rate variability and syncope burden. So then now we only targeted fragmented electrograms, regardless of high amplitude or low amplitude ones, in a region that is consistent with probable localization of GPs. Please remember that we perform cardioneural ablation in usually younger population. There is no structural heart disease in those cases. So the main cause of fragmentation in those cases usually related to neuronal incursions between cardiac myocytes. And according to this EGM-based strategy, we now know the possible localization of GPs around left and right atrium. The first one is right superior GP located between posterior septal wall of superior vena cava and anterior wall of right superior pulmonary vein, which is very important for vagal innervation of sinoatrial node. The other one is right inferior GP located in interatrial septum area. The other one is Marshall tract GP. It's very close to the vein of Marshall site, and it's a real completely epicardial GP sites. And so during endocardial ablation, it's not easy to see fragmentation in this site, and so you can miss some of this fragmentation in mapping. The other one is left inferior GP located in posterior wall of left inferior pulmonary vein ostium. The other one is left superior GP located between left superior pulmonary vein and left atrial appendage in roof area. And the last one is posterior medial left atrial GP located around coronary sinus ostium, and it is very important for vagal innervation of AV node. So let's check the treatment option of reflex syncope according to the latest ESC guideline. As you know that according to the guideline, in the first attempt, you should differentiate the contribution of blood pressure on occurrence of symptom or syncope. If you see low blood pressure phenotype like pure vasodepressor type or mixed type with dominant blood pressure component, we have two medication options. And I think that according to the latest research by Canadian groups, Carlos Morillo and Satis Raj, I think that in those cases, the first option should be midodrine. But you can also use fludrocortisone in those cases. If there is clear prodromal symptoms before occurrence of syncope episodes, we can try counter pressure maneuver or tilt training. But if there is no or very short prodromes, we have no such an option. But according to the guideline, please remember that if there is dominant cardioinhibitory response and if the patient is younger than 40 years old, we have no any well-known treatment option, because in all cardiac pacing study, only patients older than 40 years old included in the study. Especially if you look at the mean age, it was higher than 60 years old in those studies. So I think that we need some well and effective strategy for younger dominant cardioinhibitory type reflex syncope cases. In this well-designed study, Van Dijk et al. Checked the heart rate, total peripheral resistance, and stroke volume levels during tilt testing in patients with reflex syncope. And as you see in here, actually during tilt testing, for example, at the beginning of the test, the heart rate level is 60 BPM, and then we see a stepwise increase on heart rate levels due to sympathetic activation. For example, heart rate level reached to 120 BPM level, and then we see a steep decrease on heart rate. But usually syncope occurs before occurrence of asystole, usually in the heart rate level of 70 BPM. So this is why classical pacemaker or even rate drop pacemaker, rate drop response pacemakers are not effective to prevent reflex syncope episodes, because you have to detect the event in the earlier steps. This is why a closed-loop stimulation system seems better than the other pacemaker modalities in this population. But if you perform cardioneural ablation, you can completely eliminate parasympathetic arm. So during tilt testing, you will only see an increase on heart rate. You will not see any decrease on heart rate levels. This is the most important point. So to select your cases, you have to demonstrate contribution of cardio inhibitory component, and I think that you can use both implantable loop recorders or tilt testing for this aim. And actually, if you look at the published data, we always used tilt testing, so it seems very effective to select a potential candidate for cardioneural ablation strategy. Let's check the relevant data. Actually, this was the first long-term study about the effect of cardioneural ablation in pure vasovagal syncope cases. Patron compared the effect of cardioneural ablation strategy by using spectral analysis and performing biatrial ablation, and you see that there was 43 patients and mean age was very young, just 32 years old, and in great majority of cases there was a pure cardio-inhibitory reflex syncope, and they demonstrated that at the end of 45 months of follow-up, syncope-free survival was higher than 90%. This was very fantastic results. And then Yan Yao from China, by using high-frequency stimulation and left atrial ablation, checked the results of left-sided GP ablation in patients with vasovagal syncope. In this cohort, there was 115 cases, and they demonstrated a similar success rate in their cohort. But as an important difference in that study, actually, in 74% of cases, there was mixed tip reflex syncope. But as another important and interesting point, in 13% of cases, there was just pure tip vasovagal syncope. This was very surprising results, because according to our theoretical belief, we should demonstrate the contribution of cardio-inhibitory component, and we can eliminate the parasympathetic arm. But they demonstrated such a response. And then Leonardo Caro from Italy performed right atrium only ablation, and they performed empirical anatomical ablation in superior vena cava site, interatrial septum area, and around coronary sinus ostium via right atrium only. And if you look at here, actually there was only 18 patients. It was a small study, but the recurrence rate seems a little bit higher than biatrial or left atrial ablation. And after 12 months, there was decrease on heart rate levels, and they changed, they found change on heart rate variable parameters. And I think that there might be a reinnervation phenomenon in right atrial ablation strategy. And now you can see our results in patients with pure vasovagal syncope. We have 51 cases, and they are very younger population, and we demonstrated almost 95% syncope-free survival at the end of study. But as an important point, actually we checked tilt testing not only before the ablation, we also checked follow-up tilt testing at the first and 6 months of the follow-up, and actually without any new syncope episodes, we saw some vasodepressor type response on follow-up tilt testing in some cases. So I don't suggest to use cardioneural ablation in pure vasodepressor type reflex syncope cases, because according to our experience, we don't have any effect on vasodepressive component by using cardio ablation strategy. And then we published the first case control study. In the one arm, we performed cardio ablation, and in the other arm, the patient just receive a conventional treatment. But as an important point, this was not a prospective or a randomized study, just a case control study. This is an important point. But as another important point, in the cardio ablation arm, the pre-enrollment syncope burden was very, very higher than the conventional treatment arm. So we selected poorer cases for cardio ablation. But despite this significant difference, at the end of the follow-up, CNA caused a 77 relative and 36% absolute risk reduction on syncope. And now you are seeing our unpublished meta-analysis with Professor Satish Rajan, Carlos Morillo, and Robert Sheldon, and we compared different ablation approach according to syncope recurrence, and we found that right atrium only strategy seems related to higher syncope recurrence. And I think that the most important reason of this difference, by using right atrium only approach, you can ablate postganglionated fibers rather than right superior GP. So let's check our suggestion for reflex syncope cases in patients with recurrent and refractory vasovagal syncope after conservative and non-pharmacological therapies. By using ILR or tilt testing, if you see dominant cardioinhibitor response, and if the patient is younger than 40 years old, I think cardio ablation should be the first option. But in patients older than 40 years old, I think the first option should be DCLS pacemaker. But if you think to implant a rate drop response pacemaker or leadless pacemaker, I think that CNA has more data for that. In patients with mixed tip syncope, we should try midodrine or fludrocortisone before any interventional strategy. If there is still continued syncope episodes, CNA or pacemaker can be attempted in those cases, but according to our experience, CNA shouldn't be attempted in pure vasodepressive reflex syncope cases. Thanks for your attention.